everybody to our Houston Methodist DeBakey Heart and Vascular Center Grand Rounds. Welcome to all of you here in person and all our virtual audience. Thank you for making time today. You are in for a treat, I can assure you that. Before I take the opportunity to introduce our speaker, there are some housekeeping announcements for today. We are broadcasting live via live stream and YouTube. So all of you here in the room, if your friends are lazy to come here, text them to go log on to YouTube or live stream. And people here in the audience, use the microphone when you ask the question so that a virtual audience can listen to it. And the recording will be available for viewing after, like all of our grand rounds. And for all of you who are here and virtually, subscribe to our YouTube channel because you get alerts of all these grand rounds. It's a wealth of information that's available. And for our viewers, if you want to submit your questions, text DeBakey, D-E-B-A-K-E-Y, to 37607. Again, text D-E-B-A-K-E-Y to 37607, and you'll be able to submit your questions. And you can also submit the questions via the live stream feed when you're watching it on live stream. We have a few conferences coming up for all of you to consider. On this Friday, that's tomorrow, March 1st, we have our Bradley Z. Nafee Amyloidosis Conference for health professionals. It's a good one-day conference on amyloid, which is kind of becoming a fast developing field. And then on the 2nd of March, the same amyloid conference is tailored to patients. So if you have any patients who are interested, make sure you can refer them to that. We also have our Robotic Vascular Surgery Summit, March 25th and 26th, Heart of a Woman Conference, April 27th, and then CVD Prevention Conference, May 4th. So you can look these up and register on our website. So with those out of the way, I am honored and elated to really introduce our Grand Rounds speaker today. Dr. Kittleson is a professor of medicine at Cedars-Sinai and director of education in heart failure and transplantation at the Smith Heart Institute. She graduated from Harvard College and received her medical degree from Yale. She completed residency at Brigham and Women's Hospital and cardiology fellowship at Johns Hopkins, where she also received a PhD in clinical investigation. She is the interim editor-in-chief of the Journal of Heart and Lung Transplantation, has been on writing committees for the 2022 ACC-AHA Hypertrophic Cardiomyopathy Guidelines, the Heart Failure Guidelines, and she's the co-editor-in-chief for the ACC Heart Failure Self-Assessment Program, and on the board of directors for the Heart Failure Society of America. She has written multiple essays, scientific articles published in high-impact journals like NEJM, Annals of Internal Medicine, JAMA Cardiology, and you name it all. And she also has a book which was published a few years ago, Mastering the Art of Patient Care. It's available from Springer Publishing, and it's a good must-read for med students and residents, I would say. And she is well known in the world of social media as Kittleson Pearls. Her tips and pearls are very precise and very intuitive for master clinicians. And I think she's done an excellent job, and I think that Mastering the Art of Patient Care reflects a lot of this. She is an author, a mom for 3 kids, and an amazing person who's really been helpful for a lot of trainees and fellows, and I discovered that she has fans that she doesn't know apart from just being famous. There are a lot of people here in our institution who wanted to really meet her. So with that introduction, thank you so much for being here. Dr. Kittleson will talk us through GDMT and heart failure, the power of pills.
Thank you. Wow, that was the nicest introduction ever, so I'm very pleased this is recorded. I wonder if my parents are listening on the live stream link. My dad stalks me on Twitter, so it's highly possible right now that he's online. So GDMT and heart failure, let's dive in. Now, one thing I didn't ask is how to advance the slides. Yeah, what do I press? Beautiful. Okay, thank you. How many cardiologists does it take to operate these slides? Now we found out it takes 2. So I have no relationships. I have nothing exciting to disclose. I'm going to talk about GDMT and heart failure. We're going to talk about heart failure with reduced ejection fraction. We're going to talk about heart failure with preserved ejection fraction. We're going to start with reduced ejection fraction. And I'm going to cut to the chase and tell you the take-home message at the beginning of the talk, which is that the 4 pillars of survival-enhancing medical therapy for heart failure with reduced ejection fraction are the angiotensin receptor neprilysin inhibitor, evidence-based beta blocker, mineralocorticoid antagonist, and the SGLT2 inhibitor. And now I'm going to convince you, based on the evidence and the guidelines, of why this is the best therapy you can give your patients with HFrEF. So when we think about heart failure with reduced ejection fraction, it's truly a triumph of translational medicine, right? Where our understanding of tiny little molecules has translated into pills that help our patients feel better, stay out of the hospital, live longer, and potentially improve heart function. And we know that initially, we knew there was the sympathetic nervous system and the renin-angiotensin-aldosterone system. These systems that were initially beneficial to the failing heart, but ultimately maladaptive, and that forms the basis of the therapies we give our patients. So let's take these systems one by one. We all know the sympathetic nervous system might be good, and back when I was in medical school, we were all told that beta blockers were contraindicated in HFrEF because that failing heart needed the sympathetic nervous system. But now we know it's ultimately maladaptive because over time this will lead to worsening heart failure. So beta blockers, it's old news, right? Beta blockers save lives. In patients who are less sick, really sick, post-MI, bisoprolol, sustained release metoprolol, or carvedilol lead to a reduction in mortality. The studies are clear, which is why the guideline recommendation is clear. And the guidelines specifically talk about the evidence-based beta blockers, bisoprolol, carvedilol, sustained release metoprolol, class 1 indication. Easy. Now let's talk about the renin-angiotensin-aldosterone system. Again, initially beneficial, but ultimately maladaptive, so blocking it is a good idea. And the story actually begins. Now, I made a cardinal sin. I made a super busy slide, but don't panic. We're not going to go through it line by line. But I have to call your attention to the first trial on this list. So the consensus trial came out in 1987. Some of you probably weren't even born in 1987. They took the sickest patients, class 4, only 253 patients, only followed for 6 months. And enalapril led to a reduction in mortality from 44% down to 26%. Can you imagine living in a world where your patient with heart failure has a chance of dying at 6 months of 44%? You can't because of ACE inhibitors. So in patients who are really sick, less sick, asymptomatic after MI, there's a reduction in mortality. Very clear. So after 1987, everyone knew what to do. Give your patients an ACE inhibitor. Now, the story with the angiotensin receptor blockers is a little muddier, not as good as an ACE inhibitor head-to-head, no good if you combine it, but at least compared to placebo, it works, but not as good as an ACE inhibitor. And that was pretty much the story that everyone knew and everyone understood until 2014. And there was recognition, of course, that there's another neurohormonal system we should pay attention to, the natriuretic peptide system. So unlike the other systems, which are bad, the natriuretic peptide system is all good. It causes lower blood pressure, less sympathetic tone, vasodilation, natriuresis. And we know then that an increase in natriuretic peptides can help heart failure patients. But you might remember there used to be a recombinant natriuretic peptide available by intravenous infusion called nasiritide. It didn't work, maybe because it was a continuous infusion, so as soon as you turned it off, the benefit was gone. But there's another way you could give more natriuretic peptides to your patients, inhibit their degradation by neprilysin, and that's the principle behind the neprilysin inhibitor sacubitril. Now, we all know it's not just sacubitril, it's sacubitril valsartan, because Sacubitril as a neprilysin inhibitor degrades other stuff too. Turns out it can lead to more angiotensin. You got to combine it with an angiotensin inhibitor. You can't combine it with an ACE inhibitor because of angioedema. So there we go. This is the theory behind which you'd think a neprilysin inhibitor should work. And of course, the practice was the Paradigm HF study, which came out in 2014. Symptomatic HFrEF was not a placebo-controlled trial. It was comparing sacubitril valsartan to the best available therapy of the day, an ACE inhibitor, and for the first time since 1987, the ACE inhibitor was knocked off its throne. Sacubitril valsartan 1 was superior, met the primary endpoint of cardiovascular death and heart failure hospitalization. So based on the heels of the Paradigm HF trial, the pivotal trial showing superiority of sacubitril valsartan over ACE inhibitors, the guidelines are very clear. The guidelines tell us in patients with symptomatic HFrEF, an ARNI is recommended. They tell us that you should only use an ACE inhibitor when use of ARNI is not feasible, and they go so far as to say if you're intolerant, you can only use an ARB if you're intolerant to an ACE and an ARNI is not feasible, and if your patient's already on an ACE or ARB, switch them to an ARNI. So this has now become standard of care for guideline-directed medical therapy for HFrEF. An ARNI is better than an ACE inhibitor, is better than an ARB based on the trials and evidence we have and the best medications we can give our patients. So that's part of the story of the renin-angiotensin aldosterone system. Now let's talk about the mineralocorticoid antagonists, the aldosterone antagonists, spironolactone and eplerenone. In patients who are less sick, post-MI, reduction in mortality, pretty straightforward. But I call your attention to this observational study shown here, which appeared in the New England Journal 20 years ago. Fascinating study. They took prescription claims data and hospital records for Canadians over the age of 65. Basically their Medicare database. And they compared 2 time points, 1994, before anyone was really thinking about spironolactone, and 2001, after the Rawls trial had percolated into clinical practice. And they compared spironolactone prescriptions, hyperkalemia hospitalizations, and hyperkalemia deaths. Good news, prescriptions went up. That's good, right? Because it means that clinicians are applying clinical trials to their patients. But not only did prescriptions go up, hyperkalemia hospitalizations and hyperkalemia deaths went up. And I think this is such a fascinating cautionary tale about applying clinical trials to our patients. You can read the soundbite, mineralocorticoid antagonists save lives, but you have to read the fine print. And what was the fine print that was potentially missed that caused this problem in these patients in Canada? Likely the entry criteria. Were these patients who were given spironolactone truly the patients in the clinical trial? Was their kidney function appropriate? Second, were they meticulously followed as patients are in clinical trials with potassium checks? So it's important when you see a patient sitting in front of you in clinic, you don't just think about the soundbite of the clinical trial, you think about whether that patient actually meets the criteria for which they would derive benefit. So a few other points, if they have gynecomastia, that's the reason to use eplerenone instead of spironolactone. Watch the potassium. And I've coined this term, indication creep, where you take a medication that's been proven beneficial for one reason and you start to creep to other reasons for which there is less benefit. So spironolactone indication creep alert, make sure you're not giving it to a patient who doesn't have the kidney function to safely tolerate it and or will get the potassium follow-up. And in fact, the guidelines are quite clear. A class 1 indication, because the data is great, with a caveat, make sure the kidney function and potassium are okay. So that takes us through 2014, where we have the renin-angiotensin-aldosterone system, we have the sympathetic nervous system, we have the natriuretic peptide system, and then of course the magical and mysterious SGLT2 inhibitors. So initially developed for diabetes because they cause glucoseuria, which improves glycemic control, but they also have these other benefits, natriuresis, which can lead to blood pressure improvement, better volume status, and also reduction in oxidative stress, fibrosis, inflammation. But what you may not know is that we have our understanding of SGLT2 inhibitors. We have to thank rosiglitazone. Rosiglitazone, remember rosiglitazone, the thiazolidine dione, FDA approved for the treatment of diabetes because it improved a surrogate endpoint, hemoglobin A1C. But then post-marketing analysis indicated it increased the risk of heart failure. So the FDA then decided in the mid-2000s, you cannot have a drug FDA approved for the treatment of diabetes unless it passes through cardiovascular safety endpoints, cardiovascular outcome trials. This was probably very bad news for drug companies because those trials would be expensive, but it led to the important SGLT2 inhibitor cardiovascular trials where empagliflozin, canagliflozin, dapagliflozin, and erdagliflozin were run through the gauntlet of taking patients with diabetes and atherosclerotic cardiovascular disease or elevated risk and testing them for safety for cardiovascular endpoints. But the drug manufacturers got really lucky because not only were these medications safe, they were effective. They reduced the risk of cardiovascular death, MI, stroke, and even more astonishing, they reduced the risk of heart failure hospitalizations, a completely unanticipated finding. So now you have these medicines, these SGLT2 inhibitors, that reduce the risk of heart failure in patients with diabetes who don't even have heart failure. Makes you wonder how they'd work in diabetic patients who actually had heart failure. And here's where the clinical trial architects took a genius leap and said, what about in heart failure patients without diabetes? And that led to the pivotal SGLT2 inhibitor heart failure trials. So DAPA-HF was the shot heard around the world, really astonishing, amazing result in symptomatic HFrEF, no requirement of diabetes for study entry, reduction in cardiovascular death and heart failure hospitalization. So I became a heart failure cardiologist in the mid-2000s. That's when I graduated fellowship. And the landscape was kind of boring at that time, let me just say. There wasn't much exciting going on. But I bided my time, I was patient, and in 2014 we were all really excited because now we have sacubitril valsartan. Then we said, we don't need any more excitement. We're grateful for what we've got. We've got all these great meds. And then 2019, the SGLT2 inhibitors, I mean, it's a great time to be a heart failure cardiologist. And really the strength of this study, it came out in September of 2019 at the European Society of Cardiology meeting. Less than a year later, the FDA extended the indication of dapagliflozin to include patients without diabetes on the strength of this evidence. Now, EMPEROR-HF was a similar trial. It took symptomatic HFrEF. It met its primary endpoint driven by heart failure hospitalizations. Does this mean that DAPA is better than EMPA? No. EMPEROR-HF enrolled a sicker population, lower EF, higher NT-proBNP, higher point estimates for events in the placebo group. So there is a class effect. Give your patient whatever's cheaper. And then SOLOIST-HF told us that acute initiation was safe. So when it comes to the SGLT2 inhibitors, the studies are unequivocal, and therefore the guidelines are class 1, strong indication for any patient with symptomatic HFrEF regardless of the presence of diabetes. So when it comes down to it, when you take your ARNI and your beta blocker and your aldosterone antagonist and your SGLT2 inhibitor, we can save a lot of lives. You know, we're not surgeons, at least I think most people in the room here are not surgeons. We don't have this dramatic way to swoop in and crack open chests and restore heart function, but we can still do a lot to help our patients and take the two-year mortality of HFrEF from 35% down to less than 10% if these medications are implemented. And that is why we now talk about quadruple therapy in heart failure, and that's why we have these strong, unequivocal class 1 recommendations for these therapies. Now, if you're a purist, you might say, but you don't have a head-to-head trial of these therapies. And it's true, but you can do a cross-trial analysis taking quadruple therapy, ARNI, beta blocker, MRA, SGLT2 inhibitor, and comparing it statistically to conventional old school therapy, ACE beta blocker. And if you do that, if you do that mental statistical experiment, you can see there's 6.3 years of lives saved, making this the new therapeutic standard. And when should you start these medications? You should start them yesterday. Because if you do an analysis of when the survival curves separate on this therapy, so the figure on the left comes from the PARADIGM-HF trial. And after being on sacubitril valsartan for 8 weeks, the survival curves separate. The figure on the right comes from DAPA-HF. Improvement in outcomes after 4 weeks. These medications should be started as soon as possible. There we go. What just happened here? Sorry. Okay, there we go. But there's other stuff out there, and you've seen the hydralazine isosorbide dinitrate, ivabradine, varisequat. Where do these other things fit into our armamentarium of patients with HFrEF? So let's talk about isosorbide dinitrate hydralazine. What do the guidelines tell us about it? The guidelines tell us it has a class 1 strong indication for patients who are self-identified as African American with symptomatic HFrEF on optimal medical therapy, but instead of the ARNI-ACE-ARB, it's a class 2B. And the data, I think, is instructive and important to look at. So you thought the oldest trial I was going to talk to you about today was Consensus in 1987, but you were wrong. We're going to talk about VHEFT1, which came out in 1986. So in the mid-80s, the raging argument among heart failure cardiologists was, how do we afterload our patients? I mean, everyone understood the pathophysiology. If you have HFrEF and you afterload reduce, you will improve stroke volume, improve cardiac output, and your patient will do better. But there's lots of ways to afterload reduce. You could give an ACE inhibitor. You could give isotyl hydralazine. You could give prazosin. Hence, VHEFT1 tested isosorbide dinitrate hydralazine versus prazosin. Prazosin clearly didn't work because no one ever talked about it ever again, but isotyl hydralazine did. So then people didn't know, should I give the ACE? Should I give the IH? VHEFT2 answered that question, the head-to-head trial that showed that enalapril won. And that's why enalapril was where it was at until the Paradigm-HF trial came out. And then no one talked about isotyl hydralazine much anymore, right? Because after 1991, it lost VHEFT2, but there were some really enticing subgroup analyses that showed that if you were African American, that there was a benefit to isotyl hydralazine, which led to the AHEFT trial, which came out in 2004, symptomatic HFrEF, self-identified as Black, and a reduction in mortality. So this is an important finding, but we have to remember the fine print. The soundbite is, if you are a Black American, isotyl hydralazine will help you do better. That's the soundbite. The fine print is, look at the baseline characteristics of patients in AHEFT. 90% were on ACE-ARB, 70% were on beta blocker. It was not used instead of good therapy, it was used in addition to good therapy. And if you look at the baseline characteristics, you also see that the mean blood pressure at the study entry was 120 millimeters mercury. How many patients do you have with symptomatic HFrEF, class 3 to 4 symptoms, who have a blood pressure that high? It's part of the biology we know of Black Americans with hypertensive cardiomyopathy, but it speaks to the fact that there's no magic about this pill. The magic is lowering blood pressure. So this is another example of indication creep alert. If a Black American patient comes to you with symptomatic HFrEF and you put them on isotyl hydralazine without first optimizing quadruple therapy, you are robbing them of life-saving therapy by reading the soundbite and not the fine print, and a victim of indication creep alert. Okay, enough preaching about this medication. Let's talk about digoxin. I like to talk about digoxin, good old digoxin, named after the finger-like projections of the flowers of the foxglove plant, a really weak indication. In patients with symptomatic heart failure, despite GDMT, it may be considered. All of this is based on the DIGE trial, which came out in 1997, took patients with symptomatic heart failure, put them on digoxin. There was a reduction in heart failure hospitalization. The trial was an important trial to do at the time, because at the time, people thought digoxin killed patients with heart failure. But that was very interesting confounding by indication, because clinicians thought, if my patient's sick, I better give him digoxin, and they ended up dying. So a randomized trial was actually instructive at the time to show it didn't kill. But the question is, was that very important proof of principle of confounding by indication in 1997 still useful to us in 2024? And the answer is no, because 1997 was a long time ago. And if we look at what they had back then, it was not much, and we have a lot more now. So which is why I would say, I would venture to say that it's almost better to just actively stop digoxin in your patients to avoid polypharmacy, given the strength of every other medicine we have to help our patients do better. ivabradine. So ivabradine inhibits the funny current in the sinoatrial node, allows us to reduce heart rate without reducing contractility. Let's talk about the theory about why this should possibly work. So there are lots of observational analyses to show us that a lower heart rate is better in patients with HFrEF. So the figure on the left shows us patients with HFrEF stratified by baseline heart rate on entry to a clinical trial. If your heart rate's less than 70, you do better long term. The figure on the right comes from a meta-analysis of beta blocker trials showing how much does your heart rate drop when you get a beta blocker. The more your heart rate drops, the better you do. But I know what you're thinking right now, and it's probably, is this association or causation, right? Is the heart rate lower because patients are less sick, or are they less sick because their heart rate is lower? And it's hard to tease this out because titration of beta blockers is limited by hypotension and fatigue and the negative inotropic effects. But if we had a medicine that could lower heart rate without reducing contractility, would that make a difference? So that is the theory behind why ivabradine may work. In practice, it was the SHIFT study, which took 6,500 patients with symptomatic HFrEF, already on max tolerated beta blocker. They had to have a heart rate 70 or more because that was the observational analysis, the inflection point of worse outcomes. And it didn't meet its primary endpoint. And it has one trial, class 2A indication. But this is another example of indication creep alert, right? Ivabradine is not a substitute for a beta blocker. Ivabradine is adjunctive therapy for your patients with symptomatic HFrEF who are at a beta blocker at max tolerated dose. So before you reach for it, because your patient's heart rate's over 70, you will first ask yourself if they are truly on their max tolerated beta blocker. Finally, vericiguat, soluble guanylate cyclase stimulator, has lots of other magical and mysterious effects on endothelial function and myocardial function, vascular function. It was studied in the Victoria trial, a large trial, 5,000 patients, symptomatic HFrEF, had to have a recent hospitalization, so a sick population. It met its primary endpoint, so we can't fault it, but it didn't meet it very vociferously. It didn't meet it very enthusiastically. There was only a 2% absolute risk reduction in the primary endpoint, and one might have expected more in such a sick population. And this really is why the guidelines give it such a weak indication, and really you have to make sure your patient has recent worsening heart failure. And the point estimates are quite impressive, right? 30% risk of death or heart failure hospitalization within 32 months. So when I think about vericiguat, I think of it as the start of the conversation, not the end of the conversation. Meaning if I think my patient is sick enough that I'm prescribing it, I have to also be talking to them about how bad their heart failure is and what other options might be available to them. Do they need a conversation about their eligibility, candidacy, interest in advanced heart failure therapies? It's not enough to just prescribe vericiguat. So mitral regurgitation, the transcatheter edge-to-edge repair, where does that fit into our armamentarium? So you have amazing interventional structural people here. I don't have to go through the finer points of COAPT versus MITRA-FR with you, but I will point out what the guidelines tell us about the role of mitral valve TEER in our patients. So number one, the heart failure specialist is very important. You need to have GDMT supervised by a heart failure specialist. And then you need to have persistent symptoms on optimal GDMT. Then you need to have mitral valve favorable anatomy, sort of like the Goldilocks thing. The ventricle cannot be too sick or too well, right? The EF should be 20 to 50%. The LV size must be less than 70 millimeters. The pulmonary artery pressure should be less than 70 millimeters mercury. And then you may proceed to mitral valve TEER. So we consider it only in these situations because you want to make sure the patient will truly benefit. And I love this figure from a lovely editorial on it, which tells us it's useful in these criteria. It's futile if the valve is too sick or too well. And this is a great example of indication creep alert. Because how many patients have you seen that because valvular regurgitation, when it's the ventricle's fault, is by definition dynamic. It's changeable, it's fixable. And if you can optimize their GDMT, maybe put cardiac resynchronization therapy in, and it gets better, you've saved the patient an unnecessary procedure. And say you do everything right, and your patient's ejection fraction actually improves, which is the greatest feeling in the world, because as a heart failure cardiologist, you'd rather not treat heart failure. What happens then? So the TREAD-HF trial told us what to do if the EF recovers. 50 patients who started out with a low EF and their EF normalized. In half, the GDMT was withdrawn, in half, the GDMT was continued. And they looked for relapse. And really quite astonishingly, if you continue therapy, no one relapses. If you stop therapy, almost half relapse if GDMT is withdrawn. So it's really lovely when you have your 35-year-old patient in clinic with a non-ischemic cardiomyopathy who you put on max tolerated 4 pillars of GDMT, and their EF goes from 20% to 50%, but they're 35 and they don't want to take these medicines for life. And it's sometimes a hard sell to make them. It's very nice to have a trial and a guideline to tell us what to do. And the guidelines say, keep the therapy going if you have achieved your goal, which is to recover their ejection fraction. So I want to imprint this in your brain, so I'm showing you this slide again. We talked about the 4 pillars of survival-enhancing medical therapy, the ARNI, the beta blocker, the MRA, the SGLT2 inhibitor. And then we talked about the extras. If your patient is Black with blood pressure room after you've optimized quadruple therapy, then you think about isosorbide dinitrate hydralazine. If they have a heart rate over 70 and you're convinced they're on a max beta blocker, you can give them ivabradine. And if they have heart failure hospitalizations, think about vari-C-GUAD as the start of the conversation, but not the end, because that heart failure hospitalization is a marker of bad things to come. So that is the theory of why we should do this. What about the practice? This is a classic study of cardiology and internal medicine practices published a few years ago, showing us what percentage of patients with HFrEF are on guideline-directed medical therapy. And as you can see from those salmon pink bars in the figure on the left, about a third of patients are not on ACE-ARNI-ARB, a third of patients are not on beta blockers, and 2/3 were not on MRA at the time. And then if you look at the dosages, that's the pie chart, red meaning less than 50% of target dose, the majority are on less than 50% of target dose. So we're not doing as good a job as we should. Many reasons for that, of course. The systems can be flawed. We know insurance companies are very frustrating. The patients may not want to change, but it is our duty, of course, as clinicians, to remedy the factors that are in our control to reduce the therapeutic inertia. So how do we prioritize? How do we sequence these things? We have some data now to tell us what to do from the STRONG-HF trial. So the STRONG-HF trial took about 1,000 patients hospitalized with heart failure, not on full-dose GDMT, randomized to usual care or high-intensity care. High-intensity care, this study came out before SGLT2s, but ACE-ARNI-ARB, beta blocker MRA, had to be at half optimal dose before discharge, and they were titrated every 2 weeks, and they had very frequent visits. So just this simple intervention accomplished a lot. More patients in the high-intensity group received target GDMT at 90 days. ACE inhibitors, 55% versus 2%, beta blockers, 49% versus 4%, MRAs, 84% versus 46%. That's great, right? But what you really care about is did it work? And if you look at 6 months, more patients in the high intensity group felt better. 83% of them were now class 1 to 2. Only 15% had a primary endpoint of death or heart failure hospitalization, 15% versus 23%. So not only is it feasible to quickly optimize GDMT, it actually works. So STRONG-HF is a very useful proof of principle. So my approach, so if I meet a patient in the hospital, or actually this would be my outpatient approach, and I do even as a referral advanced heart failure transplant cardiologist, I still get those fresh non-ischemic cardiomyopathy referred to my clinic, which is always very exciting. And you start sacubitril valsartan, then I do metoprolol, spironolactone, dapagliflozin. So 4 to 8 weeks after I meet them, they are on GDMT, and then every 2 weeks I go up on something. Now people ask me why metoprolol as opposed to carvedilol. It's a style thing. The reason I like metoprolol better, it's once a day. So if patients feel a little fatigue from their beta blocker, I can sneak it in at bedtime to potentially reduce the intolerance of it. And I always start spironolactone at 25 because in my experience, the hyperkalemia on 12.5 versus 25 isn't so bad that I need to gingerly bring it in. And then titrate to symptoms, heart rate, blood pressure, potassium, and creatinine. And there's a lot of things you can do to educate your patients. For example, I often tell them, this might sound like sacrilege, don't check your blood pressure every day. I honestly don't want to know the numbers. Because if you feel fine, by definition, your blood pressure is fine. I want to know it before my visit with you if we're doing a telehealth visit, but all those additional data points might lead to more worry than actual benefit. And I don't like to assume they're going to fail a medicine. I want them to show me they're going to fail a medicine, meaning they feel great and their blood pressure is 96/60. Yes, I will inch something up. And sometimes you get away with it, and sometimes you don't. But the worst thing that'll happen is a little bit of lightheadedness that is certainly fixable and reversible. So don't act on numbers, act on symptoms. Try to avoid the having too many numbers that then stress the patient out, and try to prove that they fail rather than assume they'll fail. And I like this approach also. You know, there's a lot of, there's so many raging debates in the world of heart failure cardiologists. I guess we're a contentious group. And one of the current raging debates is simultaneous versus sequential initiation, rapid sequence initiation. I'm in the camp of rapid sequence. I don't like simultaneous. I don't like to start more than one medicine at a time, because then if the patient doesn't tolerate or has a side effect, I don't know which one caused it. I feel like every time you give a patient a med, it's like you're entering into a bond, a contract of trust. Take this mysterious pill and I think it's going to help you. So if I give more than one mysterious pill and they have a side effect, I feel I lose some trust if I don't know what caused it. So I like to do this rapid sequence initiation, and then I'll prioritize based on affordability the SGLT2, the ARNI, the beta blocker, the MRA. And thank goodness the one silver lining of the pandemic is our ability to do telehealth visits, so they don't have to drive through horrible Southern California traffic and pay exorbitant parking fees at the medical center to see me. We can do a lot of this over the phone with local labs. Okay, so we have to talk about HFpEF for a little bit, since the charge I was given was GDMT and heart failure, and it would be wrong to ignore HFpEF. So let's do a little dive into HFpEF. You know, the story is not as neat as the story of HFrEF. Of course, HFrEF, we have pleasing pathophysiology, which is translated into pills that help our patients feel better, stay out of the hospital, and live longer. We don't have that with HFpEF. But just one detour into diagnosis. You know, it's a much more challenging diagnosis. Your patient has dyspnea and edema, and their echo looks okay. Sometimes it's not even the heart's fault. So feel empowered as the cardiologist to say, listen, this isn't my fault. It's the kidney, it's the liver, it's chronic venous insufficiency. Sometimes that's tricky. It's hard to unring the bell of heart failure if the patient's been told that's what they have. But try to identify the primary cause so they can get the right treatment. Now, if you're convinced it is the heart, then make sure you're not missing one of those mimics. Like the ejection fraction is preserved, but there is an underlying cause for which there is disease-directed therapy. Don't miss an infiltrative cardiomyopathy like amyloidosis, which you'll hear about in your symposium to come, hypertrophic pericardial valvular disease. And then if you have convinced yourself, and I'm not one to ever advocate for more testing. If anything, I like to advocate for less testing. But I will say you must do the mental experiment on any patient you meet with dyspnea, edema, and a normal ejection fraction to say, am I missing something like amyloidosis? Doesn't mean everyone needs their monoclonal protein screen and technetium scan, but it does mean they need that mental exercise. And if you've done that mental exercise and or testing is directed, and you're convinced it truly is garden variety HFpEF, don't forget about all those comorbidities that take a village to manage. And then I like to talk about the pathophysiology of HFpEF as a bit like the parable of the blind men and the elephant. So unlike that beautiful figure I showed you for heart failure with reduced ejection fraction, with all these nice intertwining pathophysiological pathways, I feel like in HFpEF, we're a little blind. So you might know this parable. 6 blind men encounter an elephant in a field, and they all attack him from different angles. Not attack, this is very peaceful. They all encounter him from different angles, and they try to convince each other what an elephant is. And depending on whether they come by his side, or his tail, or his tusk, or his trunk, or his ear, they think it's a fan, wall, rope, tree, snake, spear. And I feel when it comes to HFpEF, we understand, we have observations about it, but we don't have a unifying whole. So we know there's diastolic dysfunction. We know there's systolic dysfunction. There's reduced arterial compliance. There's reduced skeletal muscle oxygen extraction, flow-mediated vasodilation, tricuspid regurgitation. But how this all comes together in a whole, we just don't know. Which is why I think when we think about therapies for HFpEF, they're kind of bad, promising, and then hopefully in the future. So I'm going to focus on some of the promising therapies we now have. And I actually want to start with spironolactone. So spironolactone came out in the TopCat trial now about a decade ago, 3,500 patients, symptomatic HFpEF. And it was a bit of a disappointment. It did not meet its primary endpoint, but it did meet a secondary endpoint of a reduction in heart failure hospitalizations, and patients who took spironolactone had a bump in their potassium and creatinine as expected for anyone who takes spironolactone. And that would have been the end of it, except those clinical trialists took a deep dive into the data and said something looks really strange. And they did a subgroup analysis by geography. It was an international trial. Half of patients came from the Americas and half came from Russia and the former Russian state of Georgia. And there was something strange about these patients enrolled in Russia and Georgia. Their event rates were very low. So in the Americas, heart failure hospitalizations 21, 25%. In Russia and Georgia, 2-3%. Other weird thing was that patients enrolled in Russia and Georgia did not have the expected bump in potassium and creatinine when they were ostensibly taking spironolactone, which makes one wonder, it's sort of puzzling, were those patients in Russia and Georgia truly enrolled with heart failure? Were they actually taking spironolactone? But because subgroup analyses are inherently hypothesis generating, we can't say for sure, and no one's ever going to replicate this trial because these drugs are cheap and no one's going to do an expensive trial on them. But sadly, the guidelines then have to give this a class 2B, relatively weak indication on the basis solely of the benefit of a subgroup analysis. However, while I try to stick to my guns and always think subgroup analyses are in hypothesis generating, do believe in the power of spironolactone, and I do prescribe it for my patients. So that's a bit of a sadder story. So let's talk about a happier story. Let's talk about the magical and mysterious SGLT2 inhibitors, which, just like for HFrEF, have now shown benefit in HFpEF. We have the Emperor Preserve trial. We have the Deliver trial. Both enrolled about 6,000 patients. Both showed a reduction in the combined endpoint of heart failure, hospitalization, and death, and with an improvement in kidney function as well. Now, only Emperor Preserved had come out at the time of the guidelines. So the guidelines, which came out in 2022, give it a class 2A indication, but I think we can all agree that really this is a class 1 medication. This is a hugely important medicine. It's the first medication ever in HFpEF to meet its primary endpoint. It truly has become standard of care for patients with HFpEF. The story with the ARNIs is a little disappointing. Paradigm HF was amazing. It turned HFrEF on its head. I think people were hoping it would do the same thing for HFpEF. But if you look at the Paragon HF trial, it did not meet its primary endpoint. It did not meet its secondary endpoint, but the p-value was 0.056. So internet pundits made much of the fact that if there had been 7 more events in the placebo group, this would have been a significant finding. But it wasn't, right? Just because you wish something to be true does not make it so. And yes, the subgroup analysis showed some benefit in women and if you have a lower EF, but again, it's hypothesis generating. So which is why I think the guidelines give it a weak indication because the data is weak. I think if you have an excuse to give it, because you gotta give something for blood pressure, stick it on board, but it certainly would not be first line. ARBs, kind of same weak data. Charm Preserved, 21 years ago this trial came out, showed that there was some reduction in heart failure hospitalization, not shown in subsequent trials, so also pretty weak. But if you need something for blood pressure and the RNA is too expensive, you got an ARB that you can give your patient. Now, what really works but isn't as widely used, of course, is exercise and weight loss. I really love this trial here on the left, this bar graph, where you have these patients, average age 67, BMI 39, randomized to calorie restriction, cut out 400 calories a day, or exercise training, kind of like cardiac rehab, 3 days a week. And how do they do? Functional capacity and quality of life. And both increase your functional capacity as measured by VO2 max. Calorie restriction improves quality of life. And if you look at the forest plot on the right, that comes from supervised exercise training trials, improved exercise quality, improved quality of life. Exercise and weight loss works. It really works. There's even more data to show it works, but it's very difficult to implement, even more so because, of course, insurance does not cover cardiac rehab for HFpEF, only HFrEF. Hopefully that will change, but it's a therapy that's harder to implement because it's a lifestyle therapy. So now you're thinking about, but wait a minute, what about these GLP-1 receptor agonists? Again, a medicine initially developed for diabetes, now repurposed to help with pretty much everything else that goes on wrong in the world. And they have, of course, they help diabetes, increase insulin, decrease glucagon, but they also cause early satiety, decrease gastric motility, and that can lead to weight loss. So this was studied in particular in heart failure with preserved ejection fraction. The STEP HFpEF trial took patients with HFpEF, average BMI of 37, given semaglutide weekly for a year, improvement in quality of life, improvement in 6-minute walk test, and lots of weight loss, like 10% weight loss over a year, and sustained as we see in other trials. So is it just that exercise and weight loss are hard and semaglutide makes it easier? Or is there something intrinsically wonderful about this GLP-1 receptor agonist that's also going on? Well, simultaneous with this New England Journal publication was a publication in Nature of the subgroup analysis of how patients did based on how much weight they lost. And it's not a mystery, I think, that the more weight you lost, the farther you could walk and the better you felt. So I think we need to have more longer-term endpoints, but clearly this has become an important part of the armamentarium of management of obesity in America. So when we think about treatments for HFpEF, this comes from a nice expert consensus decision pathway document that was published in JACC earlier this year. I say nice because I was the first author, but I think it is nice. And so we say that HFpEF, give everyone the SGLT2 inhibitor. And then a loop diuretic is a necessary evil, and the MRA, ARNI are maybe useful if you have an excuse to give it, like they need it for blood pressure, fluid congestion, etc. And of course, this came out before the STEP HFpEF trial, but I think at some point we're going to be adding the GLP-1 receptor agonist to our armamentarium. Okay, so in conclusion, what do I want you to remember? When it comes to HFrEF, quadruple therapy of the ARNI beta blocker MRA SGLT2 inhibitor saves lives. An ARNI is better than an ACE, is better than an ARB. And for every patient you see, you must justify, if they're not on these 4 agents, why aren't they? And there may be a good reason, but you need to know that reason. And if they are on those agents, why aren't you titrating? What's the next step? HFpEF, diagnosis of exclusion, let's not forget, it might be the kidney's fault, it might be the liver's fault, it might be amyloidosis. I do think that the most promising therapies are our SGLT2 inhibitors and MRAs, and of course you need a village to manage the many comorbidities. And it's not really great science that saves lives. The proper equation is great science with effective implementation equals lives saved. And self-promotion makes me nervous, but my editor made me promise to include this as a last slide of every presentation I give. So this book is probably available to you for free on the Springer website because I bet your center has an institutional subscription. So check it out and please tell all your trainees about it because life is too short to make all the mistakes yourselves. Learn from the mistakes of others on how to take the best care of patients. Thanks for your attention.
Thank you for a wonderful talk. I think it's tough to compress the evidence and elegantly really make it practical. So I hope our AHA Get With the Guidelines course will just go to the sky once all the residents and everyone prescribes that.
I have a question about a specific group of patients. So, when we meet patients who have multivessel disease in the absence of angina and ACS, for example. So, our reflex is surgical consult, let's revascularize. That discussion oversees the discussion about GDMT titration. From my transplant patient experience where they have no way to be revascularized, I've seen that when we do GDMT, they get better, they feel better, they live okay, we we delist them from transplant. So what is your approach to that multi-vessel disease patient who doesn't have, of course, unstable symptoms?
It's very hard to predict the future, isn't it? Because what you're really asking is, if I take a patient with asymptomatic or their only symptom is a cardiomyopathy, so non-anginal, what am I supposed to do? And honestly, some of the trials, stitches, they're not totally helpful to us. But I think you can't predict the future, and you got to give the patient every odds and advantage of optimizing their heart function. So I do both. I'll send them for a surgical, even an interventional cardiology consult, and if they are otherwise a good candidate, meaning they're in class 1 to 2 heart failure, well compensated, they can make it through a surgery, I will do both. I will do that, and I will do GDMT. And in 3 months, when their EF is normalized and they say, was it the surgery or was it the meds? I say yes, and then I continue both. Yeah.
Dr. Kittleson, thank you so much. Such sobering presentation, considering increased incidence, such a huge burden, complex management, which is not easy, shared decision-making, cost and financial toxicity, and so much. And I'm saying heart failure, why are we not paying so much attention? Do you think it's a failure from the health system perspective, just having heart failure? And when can we get to a point where every heart failure is considered a health system failure, considering that now we have the tools of identifying the high risk, we have the tools of preventing the 3 or 4 most important causes of heart failure: CAD, hypertension management, diabetes, maybe weight loss, and lifestyle intervention. So how can we change the mindset? We are just putting out the fire. Can we make upstream investments as a medical community to really get rid of it? There shouldn't be any heart failures.
Spoken like a true preventive cardiologist. Thank you, Dr. Nasir. I'm very happy you said that. No, I mean, you're exactly right. You could almost argue that any medical condition is a failure of the healthcare system or a failure on society on some level, because so much is preventable. And whether one empowers the primary care physicians, or when one empowers community clinics like the barbershop project to get blood pressure checks so people are aware of their hypertension to get treated, whether you have medications that are actually affordable to take, you're 1,000% right. There's so many earlier ways we can implement these problems, so I am out of business.
Hi, great talk, Dr. Kittleson. Just more of a practical question. I'm sure, as we see in practice, a lot of these patients are end-stage renal disease, dialysis with heart failure. I think from a practical standpoint, how do you deal with ARNI, Spirono, and now SGLT2? What do you particularly do in your practice?
So again, when I think about someone who's got kidney failure and heart failure, I'm always thinking, well, first of all, sometimes it's not the heart's fault. It's just they happen to be unlucky enough to have FSGS and a cardiomyopathy. But typically, it's a cardiorenal thing, right? So in that situation, the conversation about GDMT is the start and not the end, because it tells me if they are so sick that their kidneys are that bad because their heart's that bad, we need to be having a larger conversation than what GDMT can do for them. So ARNIs, the MRAs, SGLT2 inhibitors, no clear benefit, and of course SGLT2 inhibitors not recommended. I might give them a beta blocker. I might give them hydralazine isosorbide dinitrate if they need it for blood pressure, but that's the start of the conversation. And the rest of the conversation is, your heart's really horrible. Your heart's so horrible that your kidneys are failing. You feel terrible. It's not a medical mystery. What other options do we have for you? Because these medicines I may give you aren't going to do very much, to be honest. So what else can we do?
Thank you.
Good morning, Michelle. Good to see you again. Cindy Martin over here.
Hi, nice to see you.
So I want to ask you to kind of venture into another little spectrum that we didn't talk a little bit about, but I really want to hear your input, is looking at kind of personalizing medicine, especially kind of related to gender in the situation with heart failure. And so specifically, I find it kind of fascinating the lack of, or let me rephrase, the lower seen benefit in women with ACE inhibitor therapy compared to men. Kind of want you to maybe talk about that a little bit. Do you treat your female patients different based on their gender, especially regarding ACE and maybe a better benefit of ARB? And then do you see that there's going to be other opportunities to kind of personalize some of this quadruple therapy in the future?
So it speaks a bit to what Dr. Nasir was mentioning, which is we know that women are different than men, but we need to tackle the problem a lot earlier. So the problem really is the trials that have been performed, right? There's a very low percentage of women, particularly in the HFrEF trials. Maybe the highest is 0.25% female enrollment. HFpEF is better because it's more common in women. But still, we don't have enough. And plus, that enrollment was not pre-specified, so you could do a post hoc analysis that's statistically robust. So anything we're saying, we know men are different than women, but all of our data is based on subgroup analyses, which are inherently hypothesis generating. So it makes me feel uncomfortable because, I sort of edge towards the skeptical curmudgeon side of medicine and say, if I don't know it's absolutely true, I feel more concerned about implementing it. So I have to say, with that in mind, I give the same GDMT across the board to men and women, ARNI, evidence-based beta blocker, MRA, SGLT2 inhibitor. And for women with HFpEF, the SGLT2 and the MRA are my two top agents. I feel that we need the better data to guide me. There's the suspicion from the subgroup analyses, but not enough. And I'm hoping with the NIH's now push for women's health initiative, there will be more of that.
Dr. Kittleson, thank you very much for a really comprehensive and amazing talk. So I'm an interventional cardiologist, and I have to ask this question about tricuspid regurgitation. I'm sure you're seeing a lot of patients, and the tricuspid interventions are on the horizon. The EVOQUE TTVR was just approved, and the TriLuminate TriClip has gone to panel. So, what is your approach? What is your feeling about these patients with tricuspid? This is a very, very heterogeneous population. A lot of them have left-sided heart failure, pulmonary hypertension, RV dysfunction. We think that we've figured out left side, but the right side is a totally different ballgame. So which patients, in your opinion, should be referred or considered for a transcatheter tricuspid intervention?
Yeah, it's such a good question. I'm not sure. I'm going to be totally honest with you. I think there's the patients I know should not be referred. And those are the patients whose RVs are just blown out and horrible. And they've got just, I feel like thank goodness for COAPT and MITRA-FR, right? And I feel we need those criteria for the right side. So if their RV is totally blown out or their PA pressures are super high, I'm not sure they're going to benefit from the valve because the process has gone too far. Or on the other hand, we've all seen, it's funny because sometimes a trainee will say to me, he's got bad TR, so I can't trust his JVP, so I don't know how to diurese him. And I say, but no, because TR is a dynamic lesion, and if you make him euvolemic, the TR will get better, and therefore the V waves will go away. So you have to give, so the two types I don't like to move forward is the RV is too far gone, or I can diurese the TR away. But there's that middle gray zone as you talk about, which I think is the right group, but as a skeptical curmudgeon, I haven't sat with the data long enough to really have my internal criteria. And I'm hopeful that the next iteration of the guidelines will have more guidance for clinicians in general about that. As an interventionalist, is that an okay answer? Okay, thank you.
Well, I think you bring, we have time, so we have time for other questions. But to Sachin's point, it's what I've realized, and I don't know if you agree, is generally heart failure is across the board and all cardiologists are seeing. No one's going to refer to you for GDMT titration.
And they shouldn't, I agree.
But it's become easy. I've seen patients who get referred for, MitraClip or TEER or tricuspid, and then lucky that we're integrated. I mean, we picked up patients with like PH for years together who appropriately don't get it. So it's become the fancy thing to refer. So to answer your question, everybody who has severe TR, let them see you and then we'll take over.
Yes.
Yeah.
And I've never fixed a mitral valve, so you win. You can do my job and yours.
Doctor, thank you for an amazing review and summarizing the data so eloquently. I just two questions. One, you you showed that even if the big center has a heart failure, the struggle of starting this GDMT and titrating them and follow-ups every few weeks, labs follow-up. So even we struggle as a heart failure cardiology doing it. We have a lot of internal medicine, residents and colleagues here. And I think we see a small percentage of these patients in our clinics. I just want to, ask your advice and structure that you recommend for a general cardiology, for medicine, colleagues, how to approach these patients. That's one question. Second, I kind of build up from what Dr. Goel said. We see a lot of patients with a structural heart disease, tricuspid. Thanks to Sachin, half of my clinics are this patient. So I just want to get your thoughts, our role, the story of heart failure involvement in the structure, where it's going, and the opportunities from there.
So the first question, you're right, GDMT titration is not rocket science. Pulmonary hypertension is rocket science. I would never give a talk about that. So it really, I think, a stepwise approach, and I think a lot of pharmacists in some programs are involved, and then the nurse practitioners are involved, making it an automated program where every 2 weeks you go up, and as long as the creatinine's above this, lower than this, and the K is below this, and the heart and the blood pressure is above this, go to the next step. So I think implementing such an algorithm for the pharmacists, nurse practitioners, internal medicine, general cardiology to implement is great. And then it includes if X, call the heart failure cardiologist. Because I don't know, if the blood pressure is 88 and they feel great, maybe I would do nothing. So I think that kind of a algorithmic approach is possible. Second, medicine is a team sport, right? It's becoming more and more of a team sport every day. We feel like we know more and more about less and less as we get hyper specialized. So I think it's so important for the structural team to collaborate with the heart failure team to make sure the right patients are getting the right intervention to avoid the indication creep. So our role is to ensure, 1, GDMT is optimized, 2, they can benefit from that intervention, 3, there isn't another diagnosis that may be messing things up, and 4, is advanced therapy is actually the right approach for the patient at this time. So I 100% agree with you that collaboration is essential.
We have a few questions online. I don't want to neglect our online viewers. I'll just make it brief and maybe...
I'll give you one-word answers.
I think that's good. It's about exercise, physical exercise recommendation for HFpEF versus HFrEF.
Same. I tell patients basically with any heart condition, save maybe competitive athletics and HCM, exercise with common sense restrictions. You feel fine, keep going. You feel tired, stop. I don't care what your heart rate and your blood pressure are, just do your thing.
And exercise impact on LV hypertrophy in HFpEF patients, and what are the limitations?
I think every time are you going to get an athlete's heart? I think if they could exercise enough to get an athlete's heart, they wouldn't have HFpEF.
That's fair. And the last, I think, relevant question was about beta blockers in HFpEF.
Oh, I'm so glad you asked. I'm so glad you asked. That is like the best question ever. Okay, there's this thing like now, indication creep. Let's give beta blockers to everyone with heart failure. No. Remember the pathophysiology of HFpEF, like any restrictive cardiomyopathy. Is there a fixed stroke volume? What is the consequence of a fixed stroke volume? 2 consequences. Number 1, you're very dependent on your heart rate to maintain your cardiac output. Don't blunt their heart rate. Back in medical school, we talked about lucitropy with beta blockers to relax HFpEF. No. They feel worse. You'll be the best doctor in the world if you get rid of their beta blocker, unless they need it for rate control and AFib or something, and if so, minimize it. Second, remember that these HFpEF hearts are stiffer, like amyloid hearts. They don't like afterload reduction. They can't augment their stroke volume to a reduction in afterload, low threshold to back off on vasodilators if they have symptomatic orthostasis or acute kidney injury.
Thank you. Two questions, short questions.
Dr. Kittleson, thank you so much for the talk. I'm just going to follow up on Dr. Yusuf's question, but from the patient perspective. What's your approach when we tell middle-aged patient that you will be on 4 medications? Because a lot of time they just open their eyes and then panic.
Yes.
And they don't feel as bad. I think despite the fact that heart failure has very bad outcomes, that sense of impeding death that they get with cancer, for example, they don't feel it. So scaring them that you will die is not as effective, I think.
Yeah, go on, sorry.
I don't usually do that, but that's usually that's what patients are worried about, because I'm gonna die, I'm gonna have a lot of hospitalizations.
Yeah.
What's your approach to starting these medications with patients?
So in a way, a patient will lead you, right, to how much they want to know and what type of how much of their prognosis they want to understand. But the bottom line is this. I tell them, I've done my job if you feel great, and these medications are making you feel great. And you're the boss of your body. I'm your medical consultant. But ultimately, if you want to feel better, stay out of the hospital, live longer, and potentially improve your heart function, these 4 medicines will do it. They don't cause long-term toxicity and build up in your organs and cause horrible things. So you, as the patient, the boss, need to balance the inconvenience of taking 4 pills a day for the rest of your life with feeling awesome. And then you can make that decision. That's what I say.
Outstanding talk, Michelle. I love the metaphor with the creep. One creep I think we're leaving out, and I think we shouldn't. What about the hidden effect of obstructive sleep apnea and the effect on this? That's one question.
Yeah, you're totally right. You're totally right. We know that sleep apnea is prevalent in HFpEF and HFrEF, and we know that if you fix sleep apnea, patients feel better. So you're 100% right. We should have a high index of suspicion, daytime somnolence, headaches, snoring, body habitus to do an evaluation. And because medicine is a team sport, I don't think anyone should feel bad if they don't order the study themselves, but they refer to their internist and or a sleep specialist to do more. But you're absolutely right. That is part of the comorbidities that we need to manage. Agree.
And the last point, we're good at writing prescriptions for pills. And I'm going to take something I've learned, I'm a pulmonologist, about smoking cessation. What we fail to do for 50 years is not write a prescription when to stop your smoking.
Yeah.
What I don't think we're doing is we're not writing prescriptions about exercise and diet.
Yeah, no, it's so true. I've heard, or maybe I've seen studies, or it's just that when you write something down, patients take it a lot more seriously. So if we write, exercise this many times a day or stops, you couldn't be more right. There's so much we can do just for the patient sitting in front of us regarding implementation for these things that aren't scientific in pills. Agree.
Thank you very much. As you guys walk out of here, carry the message, #Power of Pills HF. If you're going to make Power of Zero famous, we got to make #Power of Pills HF famous. And it's important because I feel like in medicine, pills don't get that sexy tone of opening arteries, putting balloon pumps, but look at the errors of omission that you're doing. It's okay to have interest in all fancy stuff, but we got to hit the basics. And thank you so much for hitting the point. Appreciate it.
Thank you.
Hello before we